we're going to, thank you. I hope that's okay with everybody. Let's dive in and first of all hear from Carol, introducing somebody new who will not remain new for very long. So Carol, the floor is yours.
Thank you. You are our fearless facilitator, Patrick. So thank you for that intro. I am so thrilled and I'm so pleased to be able to introduce to you your new Executive Director, Greater Columbia ACH Leadership Council, Sharon Brown. You might know Sharon as our state senator. I know that she's met a lot of people in the past 2 weeks and she's very well known in this region. Her experience as a connector is going to be really critical as we move forward into our 3 lines of business in practice transformation, training and professional development, and care coordination through collaborative initiatives. This job is so relational. It is so important to be out in the community and connect with people. And Sharon has those skills to be able to come into this job and do it very effectively. She has she's an attorney by trade, as she specializes in contracts, which we're thrilled about because, as you know, we do a lot of contracting with our partnering providers and our community-based organizations. She did receive her law degree from the University of New Hampshire School of Law. I knew her when she got into the Kennewick City Council. Sharon and I met together and she said, so what are the landmines of being a city council person? And we kind of talked through that. And I watched with wonder as she was elevated to a state senator shortly after being elected to the Kennewick City Council. And from there, she rose to become the Vice President Pro Tem of the Senate in 2014. She's worked with a lot of our providers on especially behavioral health issues. So you can look at her track record in advancing the Youth Behavioral Health Protection Act. She has worked through trying to get coding and billing issues resolved so that we can do bi-directional integration effectively. And she was one of the state budget writers, and that is no small feat when you have to go line by line into a state budget and try to figure out where to find money for certain programs that are going to advance your community's health and interests. So we are thrilled to have Sharon on board. Sharon, I know that you're going to do well. You have a great staff that you are inheriting, and we're just really excited to have you. So welcome, Sharon.
Sharon, with that, we can clap and say welcome aboard. Do you have any quick words that you'd like to share with the group before we move on?
Thank you. Yeah, it's really an honor to be here. And I'm just going to say Carol has done an amazing job with this organization. She is so well respected across the state for the efforts that she's done here, right here in the Tri-Cities. And it's just an honor to be here and to work with her for the next few weeks. I wish I could do a Vulcan mind meld with her because she's just a wealth of information and institutional knowledge. And so I want to thank Carol for how she's moved this organization forward.
Thank you, Sharon. And hopefully you've got a little tether at your desk that you can now and then lasso Carol with and keep her close by. All right, well, let's move on to the land acknowledgement. And as is our custom, we would like a volunteer to read and put in front of everybody these sincere words of thanks to our Native peoples. So is there anybody on the line who would like to read these few short but important sentences? Don't all raise your hands at once.
Hey, Patrick, I can do it.
Okay, Martine.
We should take a moment to acknowledge that the land on which we live, work, and play contain the archaeological resources and tangible evidence of Indigenous peoples. It is the historic homelands of the Yakima, Wanapum, Nez Perce, Colville, and Umatilla people who remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you, Martine. And as we step into the Thanksgiving holiday, I think these words are all the more poignant and important. So hope we can keep those close to us as we do our deliberations. All right, let's get into the program. As you saw, I think earlier, we're going to have sort of a bigger picture in the first half of the meeting, and then we're going to have case studies following the break. But before we hear the bigger picture from Chris Delaney, we wanted to circle back and hear from Dr. Kira Mouseth, whom we heard, I want to say, a few months ago. I don't exactly know when, Dr. Mouseth, but she basically has developed a technique and a form of analysis of crises and response to behavioral responses to crises that have been very helpful to the Greater Columbia ACH. And as I mentioned, more than just our region, but throughout the state. And she's with us just for a few minutes this morning. As you can read in the bio there, she is a busy professional as a practicing psychologist and also an instructor. And I just wanted to welcome back Dr. Mouseth and hope that whether you're calling from Snohomish or Seattle University, let's hear from you about what you think is the next steps in and the evolution of the Practice the Pause campaign. So the floor is yours, Dr. Mouseth. Stacy, do you know whether Dr. Mouseth is on the call? I haven't checked.
This is Diane. I've looked, but I don't see her. I did send her another email the first thing this morning, giving her the link and everything to get on. So I'm hoping.
Okay.
But I don't see her.
Well, then, why don't we do this? Because we certainly have enough to cover in the Pam measure. Why don't we, if Diane, you could monitor that.
Oh, wait, here, she just got on. So
she just got on.
Yep.
Okay.
Dr. Mouseth, you are free to go on.
Are your ears burning, Dr. Mouseth?
I figured I was cutting it close for the 9:15, call for the day. So.
Right. Yeah, I know you're busy. So thank you for joining us. And we've just given you an introduction. And perfect. We just like to throw the ball into your court and ask for an update on what you're up to, in particular, the Practice the Pause campaign.
So I don't have an update for you specifically on Practice the Pause, but I can give you a statewide spotlight about what we're seeing in terms of behavioral health concerns and sort of trends and data.
Okay.
So the campaign is kind of in your hands, so I'm not exactly sure. I'm hoping that that's gone well, but I don't.
Yes.
That's not something that I've been tracking personally. So let me go ahead and share my screen, and I can. Sorry, pulling it up now. This is just a really brief summary. It's information that I was planning to share on the public health call tomorrow, actually. So you get a little preview, but it's a good snapshot. It's accurate data about what's going on in the state right now. So just in general, in terms of the November forecast, it's been a long time since I've seen you all and worked with you, but a lot has happened. And I think one of the most important things to understand contextually is that the Delta variant caused, in all manner of speaking, a disaster cascade, which is kind of what we were hoping to avoid, but that's not what ended up happening. So we've redone this chart, which is, I don't know if you've seen any recent updates. I redid it on October 1st to reflect the Delta variant fifth wave impacts on behavioral health and when the secondary impact actually started. So the yellow line represents our typical trajectory, and then the Delta variant secondary impact happened obviously between July and September of 2021. And anytime there's a cascade effect, it restarts the cycle over. So what ends up happening is that we we run the risk basically of experiencing a secondary disillusionment phase and a longer recovery trajectory. And that is in fact what seems to be happening basically statewide. So unfortunately, the Pulse survey data team, I'm not sure how they do their thing on a federal level, but they took a break after October, and they're not going to be collecting this particular data until December of this year again. So this is the most recent snapshot that we have of where anxiety and depression are trending. But if I were to guess, I would suspect that both of them are higher now than they were back on October 11th. And this is for people 18 and up in Washington state. So one of the most concerning pieces about the disaster cascade effect is that anytime you have two impacts within a relatively short amount of time, you are continuing to stress already taxed resources. So people are already tired, they're already kind of worn down and emotionally thin, and then we add more and more. And you know, obviously this is nobody's fault, but it's a really, really challenging circumstances when you consider the time of year, heading into the holidays, back to classroom stuff. I have two young kids, and my oldest son started kindergarten this year, and he was out in 2 14-day quarantines in the first 2.5 months of school. And so for working families trying to figure out how to navigate all of the back to school expectations and social things and the quarantines and what that does in terms of parental stress at the same time. I'm kind of switching hats between mom and clinician and disaster person and all this stuff, but it's a really hard balance for families to meet, and the kids are really struggling right now. So I'm going to show you some data about that in just a second, but one of the bottom lines here is that we really need to emphasize, I mean, practice the pause is a perfect name for where we want to be focusing our attention right now, because slowing down and working on regulation has to be one of the themes. People are so short-tempered. And I get a lot of questions saying, you know, why does this fall feel worse, right? Why does it feel like it might be worse right now than it was fall of 2020? And one of the answers to that is that, well, a disaster cascade, you know, you're starting from a lower baseline. So things are going to feel different than they did before, not necessarily in a positive way. So we want to encourage people to slow down, pausing. There's more and more research all the time about how dangerous this virus is in the long run in terms of neurocognitive stuff. And there is a study that we are referencing in our monthly forecast that's going to come out in a few weeks here. It's under peer review right now, but it's a really, really strong study. And it's looking at neurocognitive delays for kids who were infants and very young kids during the pandemic. And it's a very significant statistical difference. And I don't want to go out on a limb too far and make some assumptions about why that might be the case. There are all kinds of reasons why that could be the case, but we're looking at significantly challenged sort of neurocognitive functioning for kids who are infants or born during the last 2 years. And I don't have answers as to why, but that's something we need to consider in the bigger picture over the next 5 years or so moving forward in behavioral health. So I'm going to show you a lot of data slides right now. These are CDC sort of snapshots of what's going on. This is Washington specific data. So we're looking at psychological distress, suicidal ideation, suicide attempts, and whatnot. One indicator is higher than 2020, approaching 2019. This is everyone, right? This is all age groups. It's not separated out. I have youth data that I'm going to show you in just a second. But what is really concerning is this trend, right? The direction that this line is heading. It's not seasonally, right? It doesn't follow the 2019 and 2020 trends. We're in a very, very different pattern right now. And that's kind of alarming. Psychological distress also, just so you know, tends to be anxiety and panic, like panic attacks and anxiety. This is suicidal ideation. And these are suspected suicide attempts. Again, the direction that these things are trending is not positive, not good. I mean, I guess it is positive, but not optimistic. It's going up. And as you can see here, this basically coincides with the 2020 numbers, and this rate is higher than 2020, approaching 2019. And I know there's sort of tiny little nuance differences in these numbers, but again, it's the trend direction that we're seeing at this time of the year when people are heading into the holidays. What we're seeing in the state in terms of the numbers is more of a plateau when it comes to COVID numbers rather than the decrease that we wanted. So we had this huge spike with Delta and it's come down quite a bit and now it seems to be leveling off. And that is not where we want to be in respiratory season with flu and other illnesses, right? So it's a complicated picture that is influencing how hopeful people feel and how much energy people are bringing, basically. These are suspected overdoses, and these are alcohol-related visits. Again, the trends are in a direction that we don't like to see, and this is particularly alarming. 5 to 17-year-olds. I'm going to give you some more data on youth in just a second, but yeah. I'll be happy to take questions at the end. I did not put that picture in there, by the way. That was someone else's deck. So what I want to emphasize here is that if I could identify any particular demographic in our state who I'm most concerned about, it's people under 20, not necessarily even under 18, but it's youth and children and young adults under 20 years old. I think, as you know, I teach full-time at Seattle University, and I have had so many students in crisis this quarter. Statistically, like just on average, I've been teaching for 13 years full-time, and typically I have 1 or 2 students in crisis every year. This year I've had 6 in the last 2 or 3 weeks. And when I mean crisis, I mean like active, severe behavioral health distress in the class, right? So that's a tiny little snapshot, but it is also sort of a picture of what's going on statewide. One of the things that's happening is that Children's Hospital, and this is just an approximation, the last time I was shown the information, Children's Hospital, 50% of the acute care beds, like ICU and pediatric inpatient beds, were related to behavioral health. 50% at Children's Hospital. And there were only a handful, 2 or 3 or 4 PICU beds in the entire state that were available. So there is a crisis happening for our children and our youth right now. And I really want to just sort of galvanize energy around what we can do to support our kids and check in with them and reach out. And, you know, even kids that seem like they're doing great, just check in and ask how things are going and try to offer that sort of adult connection and support if we can. They're using spaces for children and for youth boarding in hospitals that are not meant to be. And I mean, literally like office spaces, tents, a gymnasium, hallway spaces, an elevator alcove, anywhere that they can find room. And then none of the youth who are having these places to sleep, there's no treatment. There's no behavioral health treatment that is being offered. So it's quite an issue. This is 18 and under for psychological distress. Again, the trend line is concerning. It's also important to recognize that the way the data looks on this, like this big drop, when we had the Delta, the height of the Delta variant, and I think you saw that pattern on the other data charts, there was a big drop. People were not going to the emergency departments for psychological or behavioral health issues, right? People were saying, I'm only going to go if I lose a hand in an accident or something. Like you're making different criteria around why you need to go to the ED because our system was so overloaded. So we suspect, although we aren't sure, we suspect that people were making different categorical decisions around why they were visiting the emergency department. And this is the height, this right here is the height of Delta. So we suspect that that's the case. This is drug-related visits. We're working on changing these charts a little bit, maybe to spread the y-axis out a little bit to have the distinctions be more clear between them, and it gets kind of messy in here. This is suicide ideation on the left and suicide attempts on the right, and not what we want to be seeing for sure, especially this one over here. So again, one of the things that we're trying to do for our sit reps and our reports is sort of clean this up a little bit and make it so that the data are actually a little bit more clear in terms of what it represents accurately. Right now, one of the things that my team is doing for DOH is developing what we call a Peds Packet, which is it's a three sort of category packet that's going to contain information for primary care providers, a description for what's going on, sort of like a provider alert, And then the second part will be an explanation and a flow chart about what to do for behavioral health crises. So if you have a patient coming in, an 8-year-old in crisis, what are your options and who are the next steps, right? Because a lot of primary care providers aren't familiar with the behavioral health system, right? And the process that's in place and what you can actually do. We want to advocate the least restrictive options that are available, right? Not just jumping to hospitalization. There's lots of options in between. And then we want to provide providers with evidence-based stuff, things that are included in stuff like Practice the Pause, the mindfulness techniques, the CBT, cognitive work, small snapshot, like breathing interventions, things that a pediatrician can teach a parent or teach an 11-year-old or whomever, right, in the span of 3 or 4 or 5 minutes, because we need to provide some stopgap interventions that are going to help support the youth. One of the tools, I guess, documents, products that our team has produced that I'm very, very proud of, and I strongly recommend sharing widely, is called the Think Toolbox. It's a guidebook. It's about 50 pages for parents, caregivers, teachers, coaches, mentors, for how to support K through 12 kids in this back to classroom kind of transition.
Dr. Bosseth, is
Yes,
there a way you could copy that link and put it in the chat so people can?
I will
look
do
at
that
that
after I get done screen sharing. Yes,
Awesome, thank you.
for sure. Yeah, and I'll put our whole website up, the link to it, as well as the link directly to the toolbox. So let me stop with that. I'm happy to take any questions. I don't mean to just drop this not pleasant snapshot, but I want to be honest about, what we're facing and what we can do about it, really. It's about active listening. It's about reaching out and offering support to families and to youth, because like it's clear there's quite a bit of a crisis for that demographic right now going on.
All right, thank you, Dr. Mouseth. Let's take some time for a couple questions. I'm sure there are some. We don't have any in the chat, but just go ahead and speak up. All right, while we're waiting for people to speak up, Dr. Mouseth, I'm just gonna have maybe Carol tell you a little bit about what's happened with Practice the Pause, since you haven't heard back from us since then, and I think you'll appreciate the story.
Great.
I think I'm going to tag team with Diane since she is leading this project. But Dr. Mosseth, thank you so much for coming back. It's the worst news that I was fearful of. I know that stress all over the place has manifested in so many different ways in the workplace and for our children. And unfortunately, we are in an area that is a hot spot. Benton and Franklin counties has just been really deluged with a lot of COVID cases. Our vaccination rates aren't that great. There's been strife, in the school board. It's really been, it has created such a level of anxiety. And one of the problems that we had was actually getting, the schools to incorporate some of these materials into the school system. So hopefully we can circle back and have a little bit of more support, maybe from the Department of Health, in getting those materials out. Diane, I'm going to let you give Dr. Mosseth the update on exactly where we're at, though, with Practice the Pause, if you wouldn't mind.
Sure. So we took the material that Dr. Mosseth had actually provided for us around Hope, Common Care, are those 4-letter acronyms, which are the thinking skills, doing skills, and being skills. And so we took those and had hired we hired Field Group to come up with a media campaign, and the media campaign launched at the beginning of January of this year, and the media part went from like January to the end of March, but the training continued into the school districts. So we were able to get into most school districts. We provided toolkits to all of the 288 schools that are in school districts that are in our region. We had over 140,000 children in our school districts within our 9-county region. The not all school districts were ready for the information at that time. I don't think they had seen as much because the kids were still kind of on a remote basis. And going back to school this year, I think has been the challenge, and maybe it's time to circle back to those school districts and see if there's a way that we can get back into them and do some more trainings that are specific. Brisa Perez put together with the same information, more of a, this is how you do it, like the breathing skills and all of your techniques that you told us about. So she's been going around. We did some presentations for the Rotary and for the work source, and communities and schools has been really big. And so we've been really trying to get back into the school districts in the Benton Franklin area, just because they have not been part of it, and they wanted to wait till the beginning of this year to do it. So we're still using the tools. We still have printed materials. We have tons of adult in English and Spanish materials. We have tons of Spanish youth and teen. We're out of a print of the teen and youth in English, but we've definitely flooded the areas with those toolkits. And so we really appreciate your, hand in it and providing the material for it. And I took a quick look at the toolkit that you had just put in the chat. And I think this is another great tool. And so maybe this is where we can get this to the communities and schools and try to get, that flooded within the schools as well. So thank you so much for providing those materials for us, and we really appreciate it. And we have spread it all over. There are still signs that say practice to pause, like leaderboards, and we had Okanagan area wanting to just spread it through their area, and then so it started to catch on a little bit more. Spokane also the Okanagan Resiliency Campaign really wants to spread it into the Spokane area. So I really think that it's starting to catch on again. And so, but thank you so much, Dr. Massa.
My pleasure, for sure. I really appreciate just the opportunity to get any of this information out to whomever really can use it. I have been doing a ton of work with schools recently in my role with the Department of Health. And I wanted to address Amy's question in the chat, because that's directly kind of related to the information you were describing, Diane, as well as the current update. But in the last 3 weeks, the ESDs have really been interested in focusing on some of this behavioral health stuff, I guess. And in the last 2 weeks, I have done presentations for, it was ESD 101, all the superintendents. And I don't know which the other one was, but another ESD. Is it 105? That's Wenatchee? 105. So I've done.
105 is Yakima.
Oh, Yakima. What's Wenatchee? 171?
Could be, yeah.
Yeah, so it was Wenatchee area plus others, and so these are big meetings, and then I have 3 more scheduled in the next 2 weeks. So we're trying to. This is basically the behavioral health snapshot. So what I gave you, plus in addition to more context about the Cascade, about the symptoms that youth and young adults are experiencing right now, and then sort of some techniques that leadership can keep in mind in terms of prioritizing some of the behavioral health things. There is a body of work and research on what we call education in emergencies, right? And there are some tenets of that body of work that are very, very clear. And one of them is that curricular goals are almost impossible to meet until or unless behavioral health management is part of the priority. So it can't go the other way around, because neurocognitively speaking, children can't attend to and retain new information and then hold that in their brains and then move forward unless they're at a particularly sort of, you know, neurological ability to focus. They're in a sort of emotionally stable place. It's very, very similar to having a hungry kid try and learn, right? It's the same kind of situation. So I do think they're taking it seriously. I think they're very concerned right now based on the things that they're seeing. I spoke to the superintendent at Davenport, and he said that they've had 2 kids hospitalized with behavioral health issues and none hospitalized with COVID. And it's like, well, let's get on this. And yeah, so I do think there's an interest. I do think that there's a sense of urgency around it, and I am out there beating the drum as much as I possibly can. So yeah, thank you for the question, Amy.
Okay, are there any more questions of Dr. Mouseth? Because this is quite a resource, and we appreciate all your experience, your acumen, and your enthusiasm for this issue, Dr. Mouseth. So before we move on, I'd just like to take advantage of your time, the limited time you have, to take a question from anybody in our 9 counties who are on the line that might want to follow up with her.
Do have a hand raised by Amy.
Oh, I just want to say thank you. Yeah, and I really wanted to give the clapping, but I couldn't find the clapping. So thank you very much. I've seen some of the presentations you've given to the local health officer meeting on Fridays, and it's so timely because, yeah, we were seeing the same thing down here in Walla Walla, that there's an increased need for behavioral health services for youth. There's a lot of pressure on youth right now for the curricular goals, and there's just, yeah, like you said, getting that message across. So I'm going to try to put my hand down now. Thank you.
Yeah. I will be doing this same update. That I can't give you the slides until that public health call tomorrow afternoon. So yeah.
I think we can wait. Any other questions of Dr. Mouseth then about how we might incorporate these tools and these insights into our work?
Well, again, Patrick, I think it really goes back to that the thought about the school systems and trying to work with them somehow to get these materials or reintroduce these materials into their hands. So having this emphasis from the state level come down through the ESDs is extremely helpful, Dr. Mouseth, because, you know, who is Greater Columbia to say, here, take these materials and use them, but having more direction, I think, even from the governor's office or the Department of Health, just to say, hey, these are great tools. I built them. You can use them. Contact Greater Columbia ACH. I know that you are going in front of the Badger Club, I think,
Yes.
this afternoon.
Yes, today. Yeah.
So please mention these materials. We have them on hand, and we are more than willing to give them out. Brees has done several presentations, and so we've been able to get them into hands of Rotarians and domestic violence conferences, and they've been extremely well received. So any way that we can help spread the message, just please let us know.
Will do. Thank you so much.
Right. Well, good luck with the Badger Club. That's quite a group, and I think you'll enjoy your session there. And we hope to have you back, maybe with trend lines going in different directions in a few months.
Hopefully so. Yes. Thank you so much. Appreciate it.
Okay. Take care. So let's move on now to the patient activation measure, and perhaps a bit of a turn, but maybe not, if we can see the patient activation measure used in the kind of world that Dr. Mouseth is in the middle of. And you saw the bio, I think, a little bit on Chris Delaney, the CEO and founder of the company that has taken really the patient activation measure to the market and be able to bring it to a lot more people than it's, I guess you might want to call it the inventor at University of Oregon. That person is Chris Delaney, and he is going to give us an overview shortly about what Insignia Health is doing with the patient activation measure. But to tee that up, we've asked Rhonda Hauff, whose organization has been a proponent, user and proponent of Pam. And Rhonda, as you may know, is a longstanding member of this organization and has been chair of the board until a year or two ago. So Rhonda, would you mind teeing this up for everybody on the call?
Thanks, Patrick. So before I do that, you know, we are a week out of our holiday season. So in the spirit of thanks and giving, I guess I would like to start just by expressing my gratitude for Carol. I think this is our last meeting with her. And you were very nice by saying I was a longstanding member, which is another way of saying I'm old. So thank you for your graciousness, but I do want to express my appreciation for Carol. You know, I remember where we started and none of us could say what the accountable community of health even was. And we struggled for many months even trying to describe who we were and what we were doing. And we've come a long way since then. So I just want to take a minute to say thank you, Carol, for guiding all of us through this last 5 or 6 years. So back then, and this was not an initiative of Yakima Neighborhood Health Services. It actually started with the Yakima County Healthcare Coalition. And as you all know, or I think you all know, the Greater Columbia ACH gives a certain number of funds to each local health improvement network, which in Yakima County is the Yakima County Healthcare Coalition, to do initiatives in our communities that we think might improve our population health. And in the early days of the ACH, one of the things that we talked a lot about was if there was a way that we could standardize our efforts around care coordination, because we talked a lot about chronic care management, and we were all sort of doing that in our own way. When we brought those discussions back to our local coalition, one of our organizations at the time, and it was Comprehensive Mental Health, now known as Comprehensive Healthcare, was using the Pam measure and had been using it for a couple of years. And they talked about how they felt that that was really effective within their organization as a tool for their care coordination, care coordinators. So we had asked for a demonstration at the coalition. And then we also had one of our managed care organizations that participates in our coalition who was using it for chronic care management at the state level, and talked about maybe we could do that as a pilot with any organization that was willing. And we used our LIN funds to help pay for those licenses. So it took us several months because we have a very eclectic group of providers and social service agencies and community health centers that are involved in Yakima County. And so after several months of evaluation, we decided to try that. And so we are in I believe we're just starting our 4th year of the PAM measure, and we have 5 organizations that continue to use this. And it has done, I think, what we hope. We each have a different group of patients, and you'll hear that today when you see some of our case studies. I think we're hearing from 3 different organizations, ours included, that are using it for different pilot or different patient populations. But for us at Neighborhood Health, you know, I think it really provides some of the feedback to our own care coordinators on the impact of the work that they're doing with our patients. So that's my introduction. And with that, I will turn it over to Chris. Thank you.
Thank you, Rhonda, and thank you for giving us some context in the Yakima area. We'll hear a little bit more about that as you were was just alluded to after the break. But Chris, welcome from wherever you are, whether it's Portland, whether it's Minneapolis, and the floor is yours for the next 25 minutes or so. So take it away.
I shall. Really nice to be with you all. Let me share my screen. This will do the trick.
Yeah, we see it.
All right, one more step here for the full screen. Almost there. There we go. Are we all looking at one screen?
Not yet. We still get the sort of the working view.
Okay. Maybe I'll just take another second. Still lagging?
Still have that view, correct.
Okay. Review, pause share, and Resume share.
There you go.
There you go.
Well, this is behind the scenes. It's not the full.
Great. I've actually never used the pause share and resume share. That's what it does. Great. Well, again, really nice to be with you all. I'll take.
We're seeing the presenter view, not the screen view.
Yeah.
You might have to stop share, Chris, and then reshare. Sometimes it does. That.
I know what the issue could be. I'm just going to switch off of the screen and let's see, and pause and new. There. How are we doing now?
It's still the same, Chris.
Resume.
There you go.
There you go.
I overcame technology. I have a weird looking screen, but as long as it looks fine for you, then we're in good shape. So I'll take you on a bit of a whirlwind tour on PAM, with patient activation measure. My guess is that many of you are familiar with this measure, in that it actually anchors a model, an approach to working with individuals that centers on this construct of patient activation, or a person's ability to self-manage their health and their healthcare. There we go. Hopefully you moved to screen with me.
Yep.
Excellent. So the PAM, as we describe it, began a kind of a development journey back in the year 2000. And this was actually at the University of Oregon. Dr. Hibbert and colleagues, including Dr. Bill Mahoney, who's up in Bellingham and was a professor at Western Washington, and for many years was the head of research at Peace Health. They began this journey to kind of find a way to kind of measure a person's ability to self-manage. Judy's perspective was that more and more is being expected and asked of consumers, of patients. We need to understand what they're capable of taking on, what they're capable of doing. This piece of research really mirrors that sentiment. Published in 2007 in the New England Journal. It was a study that asked the question, how much of kind of behavior has an effect on illness burden or really premature death? In this piece of research, they identified about 40% of these determinants being related to behavior, kind of how we make choices and engage with our health. One could argue, and the data says this, that social determinants, we know activated people have those determinants but overcome them, like in Medicaid. We know that access to care challenges can be overcome by more activated people, and they still have those barriers, even genotype to phenotype. So one could argue that this 40% of impact might be as high as 70%. But I think it's safe to say that even at 40%, the biggest slice of the pie, there's good cause to put a lot of emphasis and focus on, well, how do we help people become better self-managers? And so that ties really well to where we are today. As you may know, we have a direct contract with CMS. PAM is being integrated into a variety of value-based models or alternative payment models. A few months back, I thought I would kind of tally up, well, what's the relationship in typical performance measures? What's the relationship to those measures and what a person controls, right? You tend to have a lot of these characteristics that I'm going to call tick box. Did you do a fall risk assessment? Did you do a depression screen? Things that a provider or a practice can do, and it's kind of a one-off. And if you look at the most popular value-based models, you see those kind of elements in orange, and that are really controlled, by the providers. Did they use shared decision-making? Did they do a screen? Did they prescribe? Did they reconcile? But you have the other side of the equation, which is it's only going to happen if the person is effectively self-managing their health. How do they score you on CAPS or HCAPS around satisfaction, as an example? Are they readmitted, unplanned admissions, ACS utilization, depression, control of blood pressure, control of diabetes? These things occur as we self-manage far away from the clinic setting. And so 60% of these measures kind of weight towards what the person does. If you look at something like Medicare Part C, tied to STAR plans, 50-50, but they're actually changing the weighting to be heavier on patient experience. So this is going to become 60-40 as well. So there is a real case to be made if you participate in any kind of value-based rubric. whether created locally or tied to Medicare. And even in Medicaid, capitation is a form of value-based care where, you're on the hook for fees and costs that are beyond an allocated aligned amount. So, this is, really connecting self-management into performance measures. So going back to 2000, the journey began to create a measure of a person's ability to self-manage or activation. I think you all use a 13-item PAM. There also is a 10-item assessment. This measure really tackles 3 domains, and think of these domains as kind of roots of a tree: knowledge, skills, and confidence. So if you look generally to the PAM questions, you could say, well, yeah, that's kind of a knowledge question. That's kind of a skills or confidence question. The survey has a very deliberate difficulty structure. Some questions are hard to respond to, some are easy. This whole journey of creating a measure that tackles a latent construct, activation or self-management ability, that has domains, that has questions that tap into the domains, that has questions that have very difficulty structure, was about a 4-year process, a 4-year journey to craft. What PAM reveals when completed is really 2 key metrics. One is a score on a 100-point scale. Think of that scale as a true ruler. We know the value of a point change, and there are hash marks on this scale. And that's pretty unique in healthcare measures. If you think about SF series, PHQ-9, anxiety batteries, fall risk assessments, these are all ordinal measures. They might give you a number, but that 1, 2, 3, 4 is no different than 1, 100, 1 million, 1 trillion. Order is useful, but when you're thinking about the precision of a predictive tool or the precision of tailoring support, the precision of a PROM, PAM is this equal interval scale like a ruler. On top of that scale, we have 4 activation levels: 1, 2, 3, 4. And we use those levels to guide resource allocation, to guide conversations, to guide goals, information, action steps. We work around the world, a good dozen or so countries, most heavily in the US, in about 40 states, and in the UK. Globally validated. So there are now 700 peer-reviewed published studies with PAM. And as I mentioned, we're working closely with CMS in the redesign efforts. And the first 2 models are an opioid model called MOM. Now, Washington is not one of the states, one of the 10 states in this model, at least as of yet. And then the kidney care model, which is 130 sites across most US states, are our 2 starting points. So you complete the measure and you have these 4 activation levels. And these are what we use to kind of guide resources, to guide conversation, guide care plan development. Individuals, patients at level 1, profoundly overwhelmed, struggling, 30% adherent to a therapy, very quiet, passive in clinical encounters, that if they even make and keep a clinical encounter or an appointment, tends to be 15 to 20%, closer to 20% in a Medicaid population. So they're struggling, but they actually gain the most. This is where we see the greatest change when properly supported. So this notion that people might seem intractable doesn't exist for the vast majority of these individuals. They know they could do more. They want to do more. If properly supported, they do gain significantly. At level 2, they look a lot like ones, starting to realize I could do more, starting to build a bit more of a skill base. Knowledge gaps aren't as significant, but still struggling. By level 3, we have patients, individuals that are capable of achieving guideline behaviors. So when you're in a clinical encounter and you are told you have high blood sugar and you have to do this, this, and this, or else, well, you can react to that. You ask questions, you're prepared to kind of take some steps. That same conversation would set a 1 or a 2 backwards. They're already overwhelmed, it would make things worse. And so, think about the difference between medical activation, what a person should be doing, as opposed to behavioral activation. What are they capable of doing, capable of taking on? And those 2 tend to intersect when we get to about level 3 and absolutely level 4, where people are really achieving guideline behaviors and becoming very good self-managers at level 4, which tends to be 25% of most populations. So we have these levels. We use them to guide resources, guide support, but never lose sight of that underlying score. As I mentioned, Pam is a 100-point scale. So think of it not unlike A1C, blood pressure, waist, weight, temperature. Those are also equal interval measures, just like Pam. And this has proven to be why Pam has become so predictive, so strong in its relationship to those other equal interval measures. We know that if scores go up on Pam, activation levels change, we will see the corresponding positive impact in lower preventable utilization, improved self-management behaviors. Two studies that bring to life the value of score change, or the change in these points. Now, the first is a Kaiser study across most of their states where they gathered Pam data. They watched these patients for 2 years, and they asked the question, if your score was different at baseline, 1 point higher, how did that affect things that were in the clinical record, hospitalization, A1C control, getting needed lab work? They found that for a single point change, so if you were a 50 instead of a 49, that was worth nearly a 2% improvement in A1C control, nearly a 2% decline in hospitalization, and a significant gain in getting needed lab work. And that's just a point. You know, we tend to find that a level 1 person can shift 10 points within 6 months, right? And so that's why you see that kind of example of, well, what if we saw a 10-point gain, which is absolutely to be expected in the course of a year and even 6 months. HIV patient studies, same kind of finding. In fact, we've really replicated this in all kinds of unpublished data sets as well. When scores go up even a point, there is about a 2 to 3% improvement in the behavior or an outcome of interest. So you think about the context of our work with CMS, Pam is a PROM being integrated at the point of care, like you get it in Epic or Cerner, or it's just part of workflows. And when we have CMS kind of really having a paradigm shift. Historically, PROMs are something you go into the patient record, you pull data afterwards, or you ask them HCAPs or CAPs, call them by phone or email. Now we're saying, let's capture the PROM at the point of care and in the future. So let's use that same year to compare change. And let's also use that baseline score to guide resources, to guide support, to help kind of improve activation. And that's a real unique position and a real paradigm shift for CMMI. A bit of insight for you on kind of how patients are managing their health, and using just heart failure as an example. In this piece of RWJ research, which is aligning forces from years back, I've added a good battery of questions around self-management, things that you'd want a patient to be working on. And you can kind of really see the difference between kind of a low activated individual versus someone more engaged, more in charge of their health. Taking medications as prescribed, 60% of ones said, yeah, I always do that. 92% of fours. Knowing what your blood pressure should be, a little over half of ones, close to 90% of fours. Fruits and veggies, 46, 65%. Physical activity on a regular basis, 37%, 69%. So you see a real shift between low and high, but also lifestyle behaviors tend to become more difficult, right? We lament, medication adherence at 50%, but it's actually as good as it gets for someone that's low in activation, right? When they deal with physical activity, nutrition, coping with stress and emotions, those are actually even harder. So there is some good news here, and that is when we work with a patient, we know that we can see gains in many areas when they make a gain in nutrition or physical activity. When they learn, I can do this with something that's actually harder, what do you know? Medication taking improves, self-monitoring improves. And so, we love programs that think holistically, like, whole person efforts. Yes, we'll help you work through kind of stressors and emotions. Yes, we'll help you prepare for communications with your care team. We'll focus on salt and calories and carbs and nutrition. We'll focus on medication taking, like, what gets in the way of your routine. We have all these paths, the rising tide lifts all boats, all these paths to affect activation, which is really cool. We're not stuck down just one corridor that says, you need to be better with your medications and dwell on that. We have different ways of really helping someone be more successful. So we've had to spend time over the years making sure that, yes, it's a measure, but it's also a model. And the model has kind of 3 core steps, right? I guess research says, 3s tend to work well and be able to kind of grab onto that kind of 1, 2, 3 opportunity. Step 1 is to measure. And our big opportunity over the years is to become more native in the software that our clients use. So we're now, as an example, into Epic, which that's 60% of the US roughly on the clinic and hospital side, where you can kind of access Pam and as part of your normal system, normal work patterns, administer the survey, get that baseline score and level. We also want you to close the circle and reassess so that we have changes in activation as a PROM, and it's a PROM at different units of analysis, right? It's a PROM for at the patient level, the coach or provider level, the clinic or practice level, the program level. And if you're CMS, well, it's across KCCs, across the MOM models, or for NHS England, it's a national vital sign. So different units of analysis as we re-administer PAM. The second step is resource alignment. So, which patients get the community health worker, the patient navigator, the social worker, more of that advocacy. That would be somebody at level 1 or 2 who might get the in-home visit, right? Really expensive use of resource, but again and again, visits in-home post-discharge always kind of return the investment for a 1 or a 2 because the readmission risk is so high. Who might get an extra phone call or longer phone calls, or you're in practice, who gets to see the health coach? That's the 2. So often, this aligning resources is a relatively more straightforward step than the third, which is tailoring support to activation levels. So now we're saying, we know the medical guidelines backwards and forwards. You have high blood sugar, you have diabetes, you have to do this, this, and this, well established. But that's great for 3s and 4s. How do we focus on behavioral activation for 1s and 2s with goals, information, action steps that can help them get to the point where they can achieve those guideline behaviors? And so I'll talk a little bit about this tailoring journey, which, it has that tension and reconciliation with kind of what people know and historically has been coaching of, if this gap, then this. And we want to see kind of a more meet people where they're at, person-centered co-creation that occurs at those lower 2 levels. A few slides just on Pam at that first step of like aligning resources, like really as a predictive tool. This is a study of about 100,000 patients looking at ambulatory care sensitive or ACS utilization. And what you find in this study that watched patients for a couple of years was if you were a level 1 and you were compared to a level 4, and this is all risk adjusted multivariate analysis. If you're a level 1 compared to a 4, you're 62% more likely to have an ACS utilization 1 year out, 40% more likely 2 years out. You see kind of risk dropping a bit, but still high for a level 2, 44%, and then down 28%, drops significantly again at level 3. So it kind of reinforces, when you think about the most preventable hospitalization, the risk really resides with 1s and 2s. Also keep in mind that there's a lot of risk adjustment done on PAM. These numbers kind of skyrocket if you say, well, let Pam be the risk model. Don't adjust on it. Let it capture all the risk. Then you'd have an even greater kind of spike in risk for level 1s and 2s if we didn't go through what's typically expected in peer-reviewed published research is this multivariate. They want to know, well, what's just Pam? What's the additive of Pam? Which isn't quite fair if you were actually the risk model. You would be the tool used to spot risk, and you wouldn't have adjustments done on you in real time in the real world, right? A cost study. This was a project done through a CMMI grant. It was really a complex care model for multimorbid patients and creating kind of a team of advocacy around them. So clinical and non-clinical, so an interdisciplinary team that worked in clinic and by phone. It operated in about 4 or 5 Western states. Stanford was part of it, and then Stanford did the evaluation, which was published here. And I've pulled out kind of the cost piece of it. So just keep in mind, these are really expensive patients that were in the program. But even with these individuals, average age 70, if you went up a level of activation, your costs went down almost 10%, 8%. If you went up 2 levels, down 15%. So this is looking at real-time change in a year. Scores of PAM go up in a year, and what happens to cost in a year. So we're not just predicting at baseline, but rather looking together as the year moves through over a 12-month period. And the study also found it worked in both ways. So if your activation were to go backwards a level, well, then costs would go up as opposed to going down with increases in activation. So this was a real rigorous view into activation shifts and at least cost with like very costly, very complex patients. A simple way of thinking about, we talked about the ACS utilization risk, the cost relationship, in many environments, we can succeed with just kind of a simple way of approaching risk. And that is, a measure of acuity or complexity, which maybe it's a fancy database model or just coach or clinician perspective. And then it's activation and thinking low, 1s and 2s versus highs, 3s and 4s. In this kind of model, if you start at the top left, you have really low complexity, high activation. So they're really good self-managers. There's nothing kind of occurring and really don't need a lot of our support. Then you have high complexity, high activation. There's often a belief that, wow, really complex, we have to put a lot of resource against these individuals. But in our model, but they're high activation. They're really good self-managers. They do really well in clinical encounters. They know how to pull resources, pull information. And so, yes, they're a key focus, but really not the red flag that you might think because they're good self-managers. Bottom left, think of as rising risk. So they're low complexity right now, but they're also low activation. So we know where they're headed. Add 10 years, add 5 years, add 15 years, and their risk factors are going to bring on conditions or a condition. And so we can start to focus on them, but it's still not the urgency of the bottom right quadrant. And that is high complexity and low activation. And these are the individuals that have the greatest risk of ED visits, ACS utilization, readmissions post-discharge, struggling with medications, kind of the whole gamut of the things that we're working to help people be more successful with really resides in this kind of red box. This is similar to a model that was started with Pam with Peace Health, 12 years ago, at least. And then now it's been adopted throughout the Midlands of the UK. So kind of the middle part of England, really. This is kind of the prevailing primary care model. One of the tools that's available to groups using PAM through the organization is coaching for activation. And here I'm just going to chat a bit about what's the kind of approach or the model behind our coaching software and coaching method. We think about 3 real dimensions when coaching. One is the information really basic to more advanced? Are their skills poorly developed to really well developed, able to achieve and exceed guideline behaviors? And are they kind of emotionally struggling, low self-efficacy, not resilient, to the other end of the spectrum, high efficacy and really resilient problem solvers? And so think about just diabetes nutrition as an example, self-management category. At level 1, we want you to kind of go after guideline behaviors, but ultimately we know that's not kind of in your DNA. It's not who you are. So let's close knowledge gaps, build knowledge. What is the plate method for diabetes? What is the glycemic index? As much as we'd love to have you using it every day, we're not going to set an unrealistic bar. So let's just get you started and make sure you really understand these 2 really important tools. At level 2, so let's start to use it more often. So let's start to make it a bit more of your routine and close any remaining knowledge gaps. By level 3, let's do it. So your routine is becoming a habit. It becomes part of who you are day in and day out, whether you're at home or eating out. You're applying kind of these 2 methods. And then at level 4, well, the holidays are coming. What are some strategies to prevent relapse? What if you have a bad day or a bad week? How to bounce back? How to push yourself maybe even further with using these methods? So the kind of risk around hospital use and preventable services resides with 1s and 2s. And for 3s and 4s, kind of closing gaps, but even pushing further. So, different strategies based upon a person's level of activation. And this kind of method is wrapped up in coaching for activation that your organizations have access to. It supports about 13 conditions. It focuses upon core areas of self-management with that idea that you can see gains broadly, kind of like the movement of a constellation, whether you focus on medications or whether it's nutrition or physical activity. If you're in one of these areas, assuming that the patient wants to work on nutrition, then you'd have possible goals. So we don't force a goal. They're kind of sequential, but it's really about what the person wants to work on. So kind of in the spirit of MI or shared decision making. If a goal is opened up, then there's possible action steps, also kind of sequential, but we're not forcing a pathway, but they are kind of in order. And these steps have resources aligned to them that can be emailed or printed or shared with a patient, many of which we've built, so PAM-based resources. And then the system kind of can track in progress, completed, and has some of those abilities to know kind of what's been worked on and what's being carried going forward. So this is a tool that the evidence, published data has shown it to be really quite effective at kind of sharpening focus, particularly for ones and twos around behavioral activation. So this tool isn't trying to reinvent anything from a clinical perspective. It's more about behavioral steps and self-management in the context of a patient. Thinking about then what's the evidence on tailoring to levels. A really good study was just published a while back, late last year, that looked across 36 studies where activation levels were used to affect patient support. And this is across the world. And they really created some findings that were systematic in this meta-analysis. One was that as PAM goes up, this is predictive of behavioral change across conditions and across studies, which means really across the world. So it's a real process measure. Interventions that had these interdisciplinary teams, not unlike that Stanford study I mentioned, where you had kind of your clinical staff, your non-clinical staff, but people working together with an individual that is kind of the center of that team. And that tailoring in this context led to significant improvements in activation. Interventions don't have to be uniquely different by every disease. You can have one model, which for us, it's kind of the roots of the tree, knowledge, skills, and competence, that you can then just nuance and adjust for specific conditions, as we do with coaching for activation. And then the key or the takeaway from this meta-analysis was, their best practice intervention would be a team approach and tailoring to activation levels. You'll have in the slides, which make sure you have a couple case studies. One is one of our earliest clients was ADSA in Washington. I think after Providence, it might have been our second or third client, if you go all the way back to about 2008. And we started in the aged and disabled program with primarily phone support. This then evolved into the health home program. And here you see kind of results from one of the initial evaluations with CMS, $105 million saved. This is largely duals, really complex patients. And then they shared kind of some of the key cost changes between the baseline period and then the follow-up period. The follow-up evaluation maintained kind of the success of the program in that seeing kind of real shifts in utilization and declines in costs as compared to what had been projected for the population. So I know this program continues to roll forward. And then, a little bit different tack than, kind of the Health Homes program. This is the University of Washington, their ACO. So it kind of skews to Boeing employees, younger population, 45 to 65. At a CMS quality conference a few years back, they shared results. They use PAM and coaching for activation. Their measures between initial and final for their population show kind of the shifts for people managing diabetes. So you see kind of a set of measures there. And then their mean PAM scores between baseline and final showing significant increase across the levels. But you see the biggest gains are really with those lower two PAM levels, which is typically what we'd expect when properly supported. And then your results. So, and you're probably familiar with this, maybe at kind of the individual group perspective, but across the groups using Pam currently, you'll see score change really highlighted right smack in the middle. So among level ones, 9 points of change. That is almost identical to our US average, which is terrific. Level 2, 8 points of change. That's a little bit ahead of the US average. Level 3's kind of flat, not uncommon. And then you see a bit of that pullback from level on level 4s. You know, any survey has a ceiling, right? You can't keep going up. So once you're very high, you can pretty much go backwards. And as well as most of our clients aren't so focused on 4s, and you shouldn't be, because the opportunity really is with 1s and 2s, and to a lesser degree with level 3s. And fortunately, most 4s, even when they slide back a bit, they stay level 4. So 72.6 is still a mean score that is of a level, beginning of the level 4 threshold. And then all the way to the right, you'll see the metrics. Collectively, you know, close to 70% of 1s and 2s increased in activation during this kind of close to 2-year time frame. So, you know, really, really solid results that are being seen in the perspective of Pam scores. There we have it, kind of the whirlwind tour. And I know a lot to go through, and I tend to talk lickety split, but what questions can I answer?
So in the, thank you so much, Chris. That was a terrific overview and lots of food for thought as I'm thinking about all the different projects we have going on across the 9 counties in Southern Washington. So I'll be interested to hear what folks have to say over the remaining course of the meeting. But we do have a question in the chat from Dr. Kevin Martin at Kittitas Valley Healthcare, and it asks about the integration of Pam into other EHRs. You said you're in Epic. Did I take it you're in Cerner, and what else have you been able to work out?
Yeah, so first, we are eager to be in any and all systems. You know, it's kind of like a great measure, a great model isn't a great measure, a great model if it's not easily accessible and part of native workflows. So we're finishing up some work to get into Cerner, obviously in Epic. I think the others that have come up and that are being evaluated are Athena and Allscripts. We've had one organization recently ask about eClinicalWorks. So many of these groups are what we call Smart on Fire capable. Think of Smart on Fire as kind of like Apple's app marketplace, where you can, you know, turn on an app, you know, in a minute or an hour. Well, it's not that fast, Smart on Fire, but with EMRs that are Smart on Fire ready, like Epic, you know, we can be live in 30 days, 60 days. And then organizations, when they want it, can turn it on within just a few days. So if there's something on your list from those groups that's Smart on Fire ready, it could be pretty quick. If not, it's a bit of a longer, but love to know kind of which EMRs you might be thinking of.
Thank you, Chris. Kevin, do you want to just follow up real quickly before we take the next question?
Sure. My organization is on Cerner. Other providers in the community are on Allscripts. I see a lot of notes out of the Yakima area that are generated in eClinicalWorks. So my selfish interest is in Cerner, at least this week, but they've been broken for the last 2 days, so it may be different next week.
Yeah. So Cerner is kind of Smart on Fire ready in that we're going to go through their code program, and Pam will become accessible in Cerner, but for anyone in there, they can't write back. So you get a score and a level or any tool in there, and you have to manually then put it in the patient record, which isn't the end of the world. At least Pam is kind of native and comes up in there. And they are like so far behind. They're saying like June. We're going through another install with Cerner that's probably going to go HL7, which is another methodology, and we're doing that for DaVita. So a big client of theirs across many states. And so we can get back to you on what any of this might mean to you for Cerner, because I know, you know, it tends to push and utilize their Powerform system, at least with the HL7.
So it's also, there are 2 distinct flavors of Cerner. There's Cerner Millennium, AKA Big Cerner, which is what people like Memorial use.
Yeah.
The Cerner Community Works, which is what those of us who are too small to get Epic's attention wind up looking at,
Okay.
where we share our implementation with 36 other hospitals,
Yeah.
other systems.
Yeah.
And our experience is that big changes tend to migrate to Community Works at a pace that's somewhere between glacial and geologic.
Yeah. Yeah, I mean, honestly, we've kind of struggled with Cerner. They're just like so far behind Epic. And it seems like they're trying to invest more on their total POP software in different parts of the US and definitely outside the US versus Millennium. But I think for the other vendors, I know two of them are more smart on fire ready. So it should end up being an easier lift for us. But what we need to do for you is, and for a lot of clients, is just publish, like, here's our roadmap. Here's when we expect other EMRs to be accessible and what's that journey. But I know Allscripts, Athena, and eClinical Works are going to be a little easier for us than Cerner, it appears.
Chris, and then you've got a couple suggestions from Yakima for Next Gen. Are you familiar with Next Gen?
Yeah, we definitely are, and we haven't had conversations recently, but that'd be another one. I mean, effectively, I think your universe looks like the rest of the country. It's Epic, Allscripts, Cerner, Athena, eClinical Works, and Next Gen. I think if we had that set, we'd be in 98% of the US. And that is actually what we're striving for. It's just surprisingly difficult. It took us 1.5 years for Epic, and they are really the most advanced to integrate.
Okay, so we're really at time with Chris's presentation, but we do want to just continue to reflect on what he said and ask ourselves, is there anything else we can learn from Chris while he's with us? Because he's a busy guy, and let's see if we have any further questions that may help us out as we look to use Pam in one of our many projects across the 9 counties. So any questions?
Patrick, this is Rhonda. I had one quick one.
Okay, Rhonda.
Chris, that was great. And, one of the things that we talked about that from the coalition standpoint, and we're hoping that, and after another year or so, that we will be able to have enough information to go back to the managed care organizations that are in Yakima County to ask for their support in helping us to continue this. I'm not sure in your presentation about the use in Yakima County if we show what the cost savings was for our pilot. Did you show that or not?
I didn't have it in there. We do, and you've probably seen it before that Laura has done for you. We have a modeling tool that just uses kind of research norms and applies it to your score change. And it is like in the hundreds and hundreds of thousands of dollars of change. Laura, do you know exactly what those numbers look like? But we do that.
Yeah, Laura shared that if she's on, but it was in excess, just with the pilots, it was in excess of $250,000 or something, if I remember. But I just wanted to share that because I think that's important, because it's sort of one of the drivers of our coalition supporting this, that we think that's important information that we hope to be able to take back to our the 4 managed care organizations currently that are in Yakima County, that we would hope that maybe going forward that they would want to support this, because it already has shown a significant cost savings for the populations that we all are serving, just among 5 organizations. Thanks.
Yeah, no, I think it's a great opportunity. And there's always a few ways we tackle that. One is just all the evidence that says scores go up, utilization declines. It's impossible to argue with it. It's peer-reviewed, published, third party, plain as day. And so there's that tack. And then there's the modeling we do that you've seen. And then if you ever want, we just finished up a big study with Molina data. We can't publish it, but it told us what we hope it would say, and that, scores go up, ED visits and readmissions and admits go down. But if you ever have the ability to share data, de-identify that has utilization data, some of those other things, we can also do custom work for you. And I think we may have offered that in the contract, or at least verbally. We offer evaluation for free, essentially, if that can ever. The challenge is, you have to have enough of a sample size and other metrics to look at. But then you'd have truly your own kind of results.
Okay, thank you. One last question to Chris before we take the break. Here's your opportunity to pick the brains of the expert. All right. Well, Chris, I assume that we will have those slides for our further digestion after today. And thank you so much for putting that all together. And thank you for taking the time to join us from wherever you are, Portland.
Yep.
Okay,
Yeah.
very good. And you're welcome to come back and join us for these case studies you're going to hear of from 3 different groups in our region,
Yeah.
or not. But we are now going to take a very quick break, and we're going to reconvene actually, it's not a 10-minute break. Sorry, guys. We're going to reconvene at 10:30. So it's a 6-minute break because we've got a pretty full agenda afterwards. So see you all in 6 minutes. All right, everyone. Welcome back. Sorry for the short break, but we just have too much good information that we're processing today. And I would again ask people who are not the speakers to mute their phones or to mute their speakers as we go through, but then please unmute them so we can have some questions. So I think we're going to get started right now. Each of the three presenters of our case studies of Pam has about 15 minutes. If you all, the three of you, could keep your remarks to maybe 10 to 12 minutes, and then we'll have time for questions because I'm sure there will be some questions. So first up is Shauna Estep, and she's with Triumph Treatment Services, where she is now the outpatient clinical supervisor at Triumph. Shauna will be followed by Rebecca Shaw, Yakima Neighborhood Health Services. You've heard from Rhonda a little bit already, but Rebecca is going to take us into a little more detail. And Rebecca is now the care coordinator supervisor at Yakima Neighborhood Health Services. And we will end up with Kendra Palomares, who's been with us, I think, for at least 2 or 3 years in our meetings. Kendra is with Catholic Charities of Central Washington, where she is now the Healthcare Transformation Director. So, Shauna, are you ready to go? Because the floor is yours.
Hi, I am. Can you guys hear me okay?
We sure can.
Perfect. So, thank you, Rhonda, for asking me to come and talk about how we've been using the Pam at Triumph. So one of the challenges for substance use disorder providers is always meeting the client where they're at. And we're always challenged to find new ways to do that. And this year, we recently started our new peer recovery support specialty services, where we've got support providers out in the community and supporting our patients here. When we first started looking at how we were going to choose the first patients to enter that program, one of the things that we looked at was the PAM. How maybe if we took the lower activation clients, starting with the 1s and 2s, and got them connected with not only a clinician working on their substance use, but with peer support in the community to start working on some of the other challenges. If we could have some different outcomes or higher success rates. So that is how we started putting together the client roster, I guess you would call it. And so we did. And what we found is when people are active in their substance use disorder, they're often not taking care of their health. They often don't have primary care providers, or if they do, they're not engaged. They have a history of higher no-show rates, higher rates of recidivism. Their dropout rates from treatment are greater. And so by meeting them with peer support, it helps to get them connected with other services and services they need. So we're starting to find that the patients that have the 1s and 2s, the activation level, are having more success in treatment. They're showing up more often to their appointments. They're better engaged. The other thing that we're doing here at Triumph is we're using their coaching for activation to develop treatment plans that include things like poor nutrition, taking medications incorrectly or not at all. We're using the coaching and we're placing that into their treatment plans based on what the client sees as the need. Again, we want to meet our clients where they are. We want their treatment plans to be individualized, specific to what the client wants to work on. And by using the PAM, we can ask them, what in this is important to you? Is nutrition important to you? For some of them, nutrition really isn't the thing that's driving them. It might be, I want to be more consistent in taking my medications. I feel better when I take my medications. So those are the ways that we are using the PAM here at Triumph. And I know I rambled through that really quick, but I don't have a PowerPoint or anything that fancy, but we're just really excited about being able to reach that client base. Now that we've got the 1s and 2s hooked up with their peer counselors, we're also bringing in people who are scoring in that 3 and 4 range. One of the things with substance use disorders is that it's always changing. Their situations are ever changing, and we want to be there to meet the need of the clients that we serve. So we're taking a look at how we can meet all of those. We just knew that starting with the lower engaged folks would serve them well to get our program started. So that's what we're doing here.
Well, thank you, Shauna. That certainly seems consistent with the studies that Chris just showed us. The emphasis on 1s and 2s leads to pretty high returns to your organization's efforts. Let's pause right now and see if there's some questions about Triumph's experience with Pam. I don't see any in the chat, but I would
Patrick, so this is Diane. I just wanted to ask, so has Triumph Treatment seen a cost savings due to using the PAM?
You know, I don't know that we've collected any data on that. It would definitely be interesting to do that. What I do know is we've seen an improvement for the people that were 1s and 2s that have been connected with their peer support. What we're seeing is greater engagement in their treatment process. They're coming in more often. We've seen an improvement with urine drug screens for them, and increased recovery. So that's really where we've kind of focused on the outcome for them.
And I can piggyback on that real quick, Shauna. So the license that we purchased from Insignia is a shared license between our 5 organizations. And so the cost savings is right now it's aggregated between the 5 organizations that shows the cost savings. And I think that's what Chris was saying is that, you know, we probably, after we get a few more, I can't remember, we have about 1,000, I think, collectively between all of us. And the cost savings is reflective of all the organizations. And so I think that the next step would be if we ask them to engage us with the evaluation, then we could probably do that, break it down by organization. But right now it's reflective of all the organizations.
Thank you for clarifying that, Rhonda.
Sure.
Okay. Hope, you've got a question. The question from Hope Baker, Shauna, is how have you integrated the PAM into your normal staff processes, and getting then a thumbs up from staff to do this?
So not gonna lie, sometimes getting staff buy-in is challenging because it is another step that they have to take. One of the ways that we do it is we present it in a way that it's beneficial to the clients that we serve. Again, we're here for the community. We're here for the clients that we serve. So talking to them about the benefits. The other way is that we talk about it for a treatment planning purpose. In the SUD world, treatment plans are always an area that we could improve upon. And so using the coaching for activation, it integrates really easily into a treatment plan. And it's got a lot of patient voice. So that's another way. And then again, sending out reminders. Hey, have you remembered to do the PAMs? but staff buy-in is always a challenge. Teresa?
All
I
right.
just wanted to add that we also sent our staff to the training with insignia. So they got that, all that information that Chris Delaney just went through in abundance with Rhonda's staff at YNH. When this all got started, we all went through the training together. So we all saw how important and impactful using the PAM could be. And that really helped our counselors to understand like why we would add this other step. And I think that that was really helpful.
Thank you, Teresa. Laura from Insignia, do you just want to just comment on the post you just put into the chat?
Yeah, hi, thanks. So I do have the ability to run performance reports for each organization as well. So so the one for Triumph does show the cost savings. And there's also a very high score change, which Chris went over in that one report. And those cost savings, because of all of our research, client case studies, et cetera, would tell me that Triumph is seeing the positive changes or meeting their goals that they were hoping for, just like Shauna reported. So yeah, I can send this to you, Shauna, and whomever else, and and I can send them quarterly. Or
thank
monthly,
you.
depending on how often that you want them. And just while I'm talking, if this is okay, as far as training, since that was just mentioned, I think that training is really valuable, especially for those individuals who will be administering PAM, whether it's to really understand the value and also proper administration, et cetera. And I think that I've mentioned recently, and if not, now that the license is renewed again, I'm more than happy to offer another full training with our senior trainer for all the organizations, or if there was a new organization that wanted to join as well. I don't think we're doing them in person yet like we did the first time around, but we definitely could do a tailored WebEx for all of the GCACH, and anybody who's involved can join that training with Eric, our senior trainer. Otherwise, we do have our monthly trainings, especially when new employees arrive, or online training, which, as mentioned, I think is, very valuable as well.
Well, just speaking, and I'll let Yakima speak for herself, but that's good news, Laura, and that's a very nice offer. Anybody from Yakima want to chime in, or from any other county?
I wrote to Laura in the chat that we would love another full training.
Okay, great. Any last question of Shauna and the experience with Triumph with patient activation measure? Real quickly, Shauna, and maybe this is true of everybody in Yakima, how long have you been doing this? Just for background?
Oh, sorry. Was that to me or Shauna?
Either or.
I came on to Triumph in July of last year, and we've been doing it the whole entire time I'm here. So Laura might know when we initially started.
Yeah, so the license started 2 years ago this month. And unfortunately, there was a little bit of a slow start because right after training and everybody was kind of getting involved and excited, unfortunately, COVID hit. And so I know, sometimes it's hard to implement a program when you're kind of in a crisis mode and just trying to make it through the day. So, so I think there was some slower start, but I think eventually it's, been well receptive. So.
All right. So 2 years in. Any other questions? Some good conversations going on in chat. Carol, is that a question of Shauna, or do you want to hold that question till we hear from the other two?
Let's hold it. Thank you.
Okay, that's what I thought. It seems to be applicable to all. Okay, any more specific questions to Triumph and Shauna? All right. Well, let's move over a little bit, but we're still in Yakima, And we're going to hear from Yakima Neighborhood Services, as I mentioned, from Rebecca. And Rebecca, the floor is yours.
Hi, thank you for having me. Today I'm just I wrote a brief summary of how we use the patient activation measure for our program for medications for opioid use disorder, which is also called MOUD. So how we use it with those patients. Sorry, I don't have any slides or anything like that.
That's okay. We're all ears.
Great. So typically, we first complete the screening for the MOUD program with our patients. We complete, part of that screening is the PAM. So we complete that when we first meet the patients. We check to ensure they have insurance and then get them scheduled with a provider so that they can be inducted into the MOUD program. The care coordinator will then add the patient to her caseload and schedule an in-person or telephonic follow-up visit with the patient, typically very soon after they've been prescribed by their provider.
Excuse me, Rebecca, you're fading in and out. Is there any way you can speak, I think, in one direction to, okay, move up a little bit? That would be helpful.
Closer. Sorry about that. Okay. This follow-up appointment with the patient is very important to ensure that the patient was prescribed successfully, got their prescription from the pharmacy, and started the medication. Many times there is some small problems that can occur that would deter a patient from starting the medication. It is the care coordinator's responsibility to problem solve these occurrences while making the patient feel supported and welcome to be here. This is the most important step of the process in getting a patient successfully started with the MOUD program. If they feel welcome, understood, and that we are glad they are here, regardless of what is going on in their lives, it makes an impact on their chances for success. Our MOUD patients must feel that they can trust us to support them, regardless of their use of illegal substances and/or lifestyle choices. Pam plays a very big role in this process. The care coordinator will then administer the PAM subsequently every 4 months with the patient on a routine basis. Typically, our MOUD patients will start out scoring as a Pam Level 1. That indicates that the patient is overwhelmed and does not feel engaged in their own healthcare or ultimately in their lives. They lack confidence and knowledge. This indicates to the care coordinator that they will need a lot of hands-on, intensive help and guidance every step of the way, such as appointment scheduling, appointment reminders, frequent check-ins, and help with problem solving. The patient will be seen weekly at first by their MOUD provider and will have frequent contact with their care coordinator. They are offered behavioral health appointments and are encouraged to get their other medical, dental, and vision needs met. Many times they may be homeless and are walked through the process of getting certified homeless through Connections, which will start the process of getting them housed. The care coordinator and patient learn more about each other over this time and process. Typically, once a patient gains some stability on the MOUD program and begins to get their own needs met, they begin to score higher on their PAMs. A patient that scores a level 2 is starting to become aware that they can do more for their health, but they are still struggling. They are starting to think about setting small goals regarding their health and well-being. When a patient scores a level 2, it signals to the care coordinator that it is time to start bringing up some small goals and ideas. Coaching the patient along the way to begin to see their health and wellness as something they have control over and are responsible for. At this point, they will still need intense support from the care coordinator. The staff continues to give the patient the PAM, and along the way, they begin to score higher. As their confidence and skill in caring for themselves and their health gain speed, they typically will score a Pam Level 3. This is when a patient will begin to feel that they are part of their healthcare team. They will be more goal-oriented and will strive to improve their self-management. A Pam Level 3 indicates to a care coordinator that the patient will still need assistance, but it is time to step back and let the patient take more control. The staff will still be there for support and resources as needed. The but the patient will need less reminders and hands-on attention. Ultimately, of course, we are hopeful that every MOUD patient will get to be a Pam Level 4, which is when a patient feels that they are advocating for their own health. At this point, they have gained confidence, knowledge, and the skills necessary for success in their goals surrounding their health and well-being. During times of struggle and life-changing events, the patient's Pam score may fluctuate. This is absolutely common, and we have seen it the entire time that we have been using Pam. This indicates to the staff person that the level of care that the patient requires at that time, and it is instrumental in developing a care plan to fit the needs of the patient at that time. The Pam has been irreplaceable for us here at Yakima Neighborhood Health Services. It is a wonderful tool to aid staff in understanding their patients and getting to know them as individuals. Over time, the Pam assists the patients in becoming self-aware and gaining independence. It is a very valuable tool that I think could be used in many settings. Thank you.
All right. Thank you, Rebecca. And we have time, a couple of minutes for some questions of the experience at Yakima Neighborhood Health Services. Nothing in the chat yet, but go ahead and speak up if you do have a question of Rebecca. Rebecca, while people are putting their hands up, let me ask a question. Do you have a sense of how the breakdown was among your population you're serving with Pam? Was it predominantly level 1s and 2s that you have been spending time with, or do you have quite a few level 3s and perhaps 4s as well?
So typically, talking about the MOUD program and how we use Pam, they are level 1s and 2s. Typically, in the first year that they're that we know them. Yeah.
Okay.
And you know, the level 3s and then certainly the level 4s, they just typically need less contact. You know, you're still checking in, but typically they have everything under control and may only occasionally need some support. And typically they'll reach out to you when they need it.
Right.
Which is, it's amazing to see.
Yeah.
It is.
It's great to see progress, right?
Yes, it is.
Well, I just thought that would be the case given what Shauna's experience has been at Triumph, that similarly with you at Yakima Neighborhood Health Services. Okay, any questions of the experience? So I assume then that you've been at this the same amount of time that Triumph has been, at about 2 years?
Yes.
Is that correct?
Yes.
Okay. And Rhonda or Rebecca, can you just let us know, did I hear something that you're in the process of renewing this and you're going to do it for X number of months in the future?
Well, we recommit the health, again, since these are LIN funds, this is a decision by the Yakima County Healthcare Coalition. And so last month in October, the coalition voted to renew the license and use our LIN funds to support this for another year. So we've just made that commitment. So we will do it for at least another year. And then I suspect we will take Insignia up on their offer to do an evaluation for us so that we can take that information on to the managed care organizations and ask them if they will consider supporting this ongoing for us. And I should mention also that some of us, I think, are also using the Pam for our health home. Several of us are health home contractors. And so we also do that with our health home populations. And those numbers are not reflected in the pilot program.
Gotcha. Yeah.
That was my other question. So can this be at the Pam be used for any type of patient? It's just a matter of you designating that patient is that type of patient, or when you've done your assessment on your patients, if they're one of the high risk, is that it's able to be used for other things besides substance use?
Oh, yes.
Disorder.
Yeah, the care coordinators administer the Pam to all of our health home clients with all of the managed care plans that we work with. And it's very successful in helping us provide care for them.
Nice. Okay, perfect.
And
Thank
Laura might want to address that, because I think that there's a wide use of this in other locations. But if Laura's still on the call, she might want to address that as well.
Yeah, I am. Yeah, I mean, we have clients from, pharmaceutical companies to care management programs to insurance plans, hospital systems, like some use it in hospitals at discharge. If they're ones or twos, then they have certain management programs when they leave the hospital to avoid readmissions. Just in CFA, the different modules, from diabetes to asthma to cancer. I mean, it's using all over the board in the healthcare field and all over the world. I'm also, I work with all of you guys and other clients in the US, but I also work in other locations from European countries. I've worked with the NHS in UK, and then I handle all of our Australia clients. So it's used there throughout government bases, again, care management programs, aging programs, behavioral health to medical, everywhere.
Laura, doesn't somebody use it with their maternal child health population?
Yeah, and that's kind of an extension too of like with one of the CMS programs. That is their mom group with the I think it's with the mothers. I'm not involved, so I might not be saying it exactly, but and the opioid use. Some have used it even with mothers postpartum that that are more high risk in general, for postnatal and infant care. Yeah, probably anything you could imagine. We have a client that is using it in that program or something very similar. And I do want to mention, I don't think Chris mentioned this, since I'm speaking at the moment, is outside of being able to integrate within your own system, we do offer APIs, which is another way where we can set it up with certain systems, depending on your platform, that you can still kind of build the survey within your system and then directly shoot that back to us. So you don't always have to enter our system for that. So some platforms, EMRs, might have that capability as well. That's just something you'd have to talk to like your IT team with. And if it's something you're interested, anybody can let me know and I can send you whatever documentation we might have on any type of integration we currently have available.
All right, thank you, Laura. That's good information. Before we shove on, I just wanted to keep the floor open for one final question of Rebecca and Yakima Valley, Yakima Neighborhood Health Services. Okay, I don't see one popping up. Carol, you've got a question you'll pose at the end, correct?
Yes.
So let us move on to the third and final presentation from Kendra Palomares, and just to correct her title, she's currently the director of Tri-Cities Office of Catholic Charities. So Kendra, let us know, if you can, what's been going on at Catholic Charities and Pam.
Sure. Do you have my slides, Stacy? There they are. Okay. So our Pam Experience, we actually started using the Pam quite a while ago. In Wenatchee, we started, because we have three main locations, Wenatchee, Yakima, and Richland. And in Wenatchee, we started in October 2018. And then in Greater Columbia, our Richland and Yakima offices, we started in April 2019. So actually before this pilot. And we administer the Pam to all of our behavioral health clients that are 18 and older. And we do that at intake and every 6 months at their reassessment. And we administer those, our clinicians or case managers administer the PAMs, and it's entered into Flourish, which of course you need to do because you need to enter it to get the actual score, the survey to get the score. And then we also put that score into our whole person care part of our EHR as well, so that we have all that information in one. Next slide. So we use the PAM for a number of reasons. We use it to get a baseline and then monitor progress ongoing. And we use it to understand the client's activation and tailor supports and services. We use it for our risk stratification. So we have a three-pronged approach. We do a social determinants of health assessment and get a score from that. We do smoking status. When we chose that as other behavioral health agency, we wanted a physical component, but we don't necessarily have the facilities to get A1C3 score, A1 scores, or other types of things that we wouldn't know offhand, or the client might not know offhand, but they know if they smoke or not. And that is a big indicator of other health needs. And the PAM. So we use those three things in deciding and coming up with our stratification for our population. And then we use that stratification to refer the highest scores to case management. And so when they get case management, they're getting more support. They really facilitate that connection with primary care, and then also connecting with community resources and really guiding them through the process. So our next slide is looking a little bit at the data and the lovely reports that Laura sends, or that you can run many of them yourself on Pam, on the Flourish software. So we have done 2,361 assessments since April 19 in Greater Columbia on 1,417 people. That was up through September, because I think I've had this on my docket for a little while. So I did this PowerPoint before I had October's data. And so you can see how our scores break down. In level 1, there was 17% of people, and that's their initial score. Level 2 is 25%, level 3, 38%, and level 4, which is the most activated, is 20%. And then a big part of it, Pam, is the re-administration. Like, that's what you want to be able to re-administer so that you can see where the scores go. And so we've been able to do that in 39% of people that enter. And why we haven't on the others is they drop off, they don't show, those kinds of things, or clinicians are overwhelmed. And it is an additional piece that people have to do. And in behavioral health, we're already doing a lot of other kind of assessments or scoring tools. So getting staff on board is a big piece of this. So for our level 1s, that's where you see the biggest point increase. And someone else mentioned that in level 1s and 2s, and then a smaller in level 3. And then, and Laura assures me that this is pretty normal, is that you sometimes see a dip in level 4. It could be for a number of reasons, right? When people come into behavioral health, it kind of brings a lot to the surface. And so I think they're sorting through a lot of things. And when you're at the top, sometimes the only place to go, it's hard to always stay there consistently. Sometimes you might go down. We can all identify, for those of us that think we might be 4s on this call, we can all know that sometimes the exercise slips away, or holidays come around and we indulge in things that we wouldn't normally. So that's where we've seen the decrease. But in the folks that really need it in the level 1s and 2s, we've seen a significant increase over time. And the cost savings on this is estimated from Flourish is $339,967 in about 2.5 years, so an average of almost $3,000 per person. So you can go to the next and last slide. So our goals, the biggest one to connect on that money piece is we don't feel we see that savings. That might be going to physical health, or it might be in other systems of care, or it could be the criminal justice system, it could be school systems, but we don't feel like we're seeing that here. And so that's what we'd really like to figure out, how to see those cost savings come back to us for all the work that we're doing with people. And then we want to continue administering and hopefully re-administering PAMs, and increase that rate and increase staff motivation around it. It can be, staff have been through a lot in the last few years. And sometimes it can, if it just feels like people have another thing to do. And so helping them reframe and shift away from that it's another thing that could have positive results. I tried to present kind of, our struggles and the positives that we've worked through. Questions?
So are we there? Are you done, Kendra,
yes, that's
with your
it.
Formal remarks?
Yes.
Okay. So are there questions of the experience with Catholic Charities and Pam? I take it the population you work with are primarily your regular clients, which would be the homeless clients, or does it go
no,
beyond that?
We were, most of our folks aren't homeless. Some are. I think Catholic Charities in Spokane works a lot more with homeless individuals than we do. This isn't our behavioral health program, so some people are, but they're predominantly low-income folks who are just trying to get by and need mental health, community-based mental health. So that's who.
Okay.
So people who are dealing with depression, anxiety, trauma, kinds of things.
All right. So here's a question from Laura on GCACH's staff, and I assume it's directed to you, Kendra, but others can weigh in.
Yeah, she's my navigator, so yes, this is a prompted question.
Okay, do you see that there?
I do.
Can you talk to that?
So the Pam Express was a tool that allows you to send it, the Pam, not administer it in person and send it via email. We had great hopes with the Pam Express that our clients would click on it and do it and maybe save clinicians a step. We found that it wasn't the case so much, at least for our folks. I don't know if they're getting so many things in email or they're not, but mostly they just ignored it. And so we've had to do it in person, but it was something we tried out and could work better, maybe with a different group of people, because we were hoping just to save time or maybe increase the frequency that we administered the Pam, because ideally we'd like to do it every 3 months, but I also want my staff to stay and not leave me. So.
Okay.
And then I see we have not used the Pam with adolescents, so you can. We've only done 18 and over, but maybe one of the other agencies has, or Laura might be able to speak to that.
Why don't we, thank you. We'll come back to you, Kendra, but for either Shauna or Rebecca, have you used Pam Express or have you used Pam with adolescents?
Hi, I can speak about that for a minute. We have not used Pam Express. We do not email or text our patients. We have used the PPAM, which is the Pam for adolescents, but in our health home portion. So not the MOUD.
Right. Okay.
But in health home, yes.
Okay.
And at Triumph, we are not using the Pam Express either, and we don't serve youth clients at this time. We don't have any SUD youth groups established right now.
Thank you. All right. Here's a question from Amy to Kendra. I don't know how you'd like to respond to this. Kendra, do you see the question about
I think
cost savings?
Yeah, I do. I think that could certainly be a part of it. I also think a lot of the activation changes they can be around behavioral health, but we're already working with people on that. And so I think a lot of the activation changes might come out in behavioral health. So it speaks to the piece of integration of how do we kind of recognize the work of each other and benefit from those things. So I think that is a piece. We certainly get new clients and continually have wait lists, but I think there's a piece of that we might be saving costs for others too.
Okay. So more questions of Kendra and the experience with Catholic Charities and Pam.
So Patrick, it's Rhonda. I have a comment.
Sure.
And I think just listening to all three of the presenters, the initial presentation that jumps out to me is oftentimes when we hear about different groups and interventions, is we hear about people waiting for people to be motivated and going for quote unquote the low-hanging fruit, to wait for people to be motivated to make a difference. And I think this is a real demonstration that you can make a difference with people by engaging them when they're at that level one. And I think all three of these presentations are really good examples of that. So, and I think the Pam tool is a really good, is an evidence-based presentation of that by engaging them early, can be effective and cost effective by engaging people early, meeting them where they're at and starting that engagement when they are at the level 1. And that sometimes can be the most meaningful in improving their health. So I just wanted to make that observation.
Okay. And it looks like most of the engagement from the 3 case studies we've seen is at level 1 or perhaps level 2. All right, we've got time left for a couple more questions, so don't be shy. We won't be talking about Pam for the foreseeable future, so this is our moment to educate ourselves about patient activation measures. While you're waiting, I've got one question for Laura, and I think this has perhaps been implicitly answered in the course of our discussion, is that the cost savings that people have talked about here are based on the model that you have there. You as, I'm talking to Triumph, I'm talking to Yakima Valley or Yakima Neighborhood Health Services or House of Charity, or Catholic Charity, you do not go through a detailed accounting of the cost savings with your CFO or your treasurer, but you rely on Insignia to give you that information. Is that true?
Yeah, so the what we say ROI, the cost savings report, we say as an expected outcome. Because of all of our research, client case studies, kind of a compilation of everything, showing that there's roughly like this average dollar amount for a point change. And so that's how it's all calculated. So we have different research backing those calculations, et cetera. Now we do have some clients that I've actually worked with where they will give us some data where we can actually then look at their claims data to compare that with the score change. Right. Or like, for instance, I have a health system down in California I work with, and we worked with them. They're actually now in the process of doing the, pulling their claims data to do a true cost analysis. Mm-hmm. But they started by just looking, their goals were to decrease ER visits and hospital inpatient readmissions or stays. And so after they implemented Pam and CFA, and they looked at the score change, it did correlate to exactly what they showed, so they had these really good results. And what they did show was after implementing Pam and CFA, they had a decrease of ER visits by 20% monthly and inpatient stays 50% monthly with this population. So they piloted it that way. Now they're expanding through the entire health system down there. So, but that was like it was a behavioral health program.
So those cost savings are related to different aspects of the healthcare delivery system and are based on averages. Is that correct?
Yeah, I mean, it could be with, like I said, ER visits, inpatient stays, any type of usage of the healthcare system, the costs that are associated with that. Mm-hmm. And for like to Kendra's point, because I know her and I've talked about it too, that, I mean, those cost savings can trickle in all, in all different areas. I have other clients that are case management programs that, the score change doesn't necessarily affect them per se. However, it's something that they can use to their partners who refer clients to them, et cetera, to show how their work could be possibly benefiting them financially. Okay. So there's value, that can expand all over the healthcare system.
Great. Thank you for the clarification. Kendra, before we shove on, any last minute comments?
I don't think so, but people are welcome if they have more questions to contact me. I'm doing Pam a while, so.
Okay. And you've been using this about 2 years yourself, or 3 years?
Yeah, actually 3.
Okay.
And can I love working with you guys and clients. Rebecca and I meet often, and she is absolute a doll. And it's been really great working with everyone. And I have to give a shout out to Kendra, love her, because we have been working together for a long time. And she has provided some really valuable feedback for Insignia over the years. And so we really appreciated that. So she's actually had conversations with, our VP of product before So we always accept that kind of feedback, and she's been really, really right on the ball with all of it. And so that's been really, really appreciative of her.
Great to hear. I mean, part of the behavioral ethos of this group, Laura, is we'd like to get feedback. That's one of the things we do.
Well, everybody's been really, really such a pleasure to work with. So I've really, I'm glad you guys extended for my selfish reasons to continue to work with all of you guys.
Good.
So.
All right. Well, thank you. Carol, you had one question. Has that been answered, or would you like to pose a question to all three of our case study presenters?
Well, it's not really as much to the case study presenters, Patrick, as it is to our leadership council, who, as you know, is kind of the think tank for Greater Columbia ACH, because they represent such a wide swath of sectors. But it just seems to me, and I applaud Rhonda for this experiment, it just seems to me that, she mentioned at the very beginning, what we'd really like to do is to take this data and these outcomes to our managed care organizations to say, hey, this is saving everyone money. Look at, I hate to say money, but really the patient should be the center of our focus. It's really improving patient outcomes. That does translate into cost savings, but wondering if there's appetite for other providers across our ACH region to do something as innovative and collaborative as what Rhonda and the Yakima County Healthcare Coalition have done. These are the types of innovations that the Healthcare Authority really was hoping that all of the ACHs would dive into, and just my congratulations to Rhonda and her leadership for piloting these sites. And I think there were actually a couple of other ones, Rhonda, that were in this collaboration, but just wondering if we think as a group, we should pursue this a little bit further and widen the net.
Well, this is a question for the LINs, and I don't know whether we have a little bit of time. I want to give Carol some closing minutes, but for those of you who are participating in the local health improvement networks, what do you think of Carol's idea? Is this something that you would think about broaching and introducing in your next go around? Anybody want to take a stab at that?
So I just have a basic question, Carol. Do the LINs, are we funding the LINs for next year?
Yes.
Okay, so they would have, the other would have opportunities to do this if they chose.
If they chose, yes.
So they probably need to take this back to their groups and discuss as a possibility. But I had a question for Laura. When Chris mentioned the evaluation, what's the denominator to make an evaluation worthwhile?
With the data evaluation?
Yes.
As far as the number of people?
Yes.
Well, obviously, the more the merrier, but I'm trying to think, we were even going to start doing one, I think that had about 400 or so individuals with readmin. So, multiple PAMs, because you need to look at that score change, and then you evaluate it with what other metrics you have, whether it's claims data, which I think is what they primarily do with that type of data report that I think he's speaking of. But I can ask him and I can send you more information on it, Rhonda, because that's more his wheelhouse than mine.
Okay, well, that's something that we probably need to talk about in the near future.
Well, and I did want to mention, since Carol brought it up too, is I know our reports, we focus or talk about those expected cost savings, but there is also a mention of expected behavior changes. So that's something, usually when I talk to clients too, we focus on. So, if you were having a medication adherence program, for instance, and so your behavior change, is to increase medication adherence, and we see that positive score change, that's where we can see kind of that expected percentage of behavior change to be happening as well. So there's all different ways we can look at the data to really evaluate the organization or their program or individuals.
Okay, thank you, Laura. It doesn't look like there's any new questions in chat.
So Carol's question, certainly I think it's interesting. I'd like to learn more. Okay. So how do you want to proceed, Kevin? Will you get in touch with, I don't know, your neighbors to the south or will you
talk directly to Laura, or
I think
that's up to you.
I think first I want to talk to our care coordination team.
Okay.
And there's a lot of places I could see this possibly being useful. There's been a little offline banter, not just in terms of lean, but in terms of our primary care clinics.
Great. Great. Okay. Well, we'll stay tuned. All right. Well, I just wanted to give the floor to our departing executive director in the last few minutes we have today. And I don't know how long her farewell address is, but we certainly would like to hear it. And I hope you'll all stay on the line for Carol Moser. So Carol, here you go.
I have to take a couple of deep breaths, practice the pause here. So Patrick suggested that I say a few words of reflection today. So thank you to all of you that have stayed to the end of today's Leadership Council. And forgive me for using my notes. I just want to make sure that I can get through this. You know, to those of us that have been here since the very beginning of this journey, and Patrick and Les Stolnecker, you were there from the very beginning. We remember those days when we were at the Walla Walla Health Department building, and Walla Walla at that time was at the middle of what we then called the Southeast Washington Accountable Community of Health, because when we started, we were only 6 counties, including Benton, Franklin, Walla Walla, Columbia, Garfield, and Asotin. So Walla Walla was kind of that midpoint where we were meeting. And our favorite saying at that time, and we used it quite a lot afterwards, was, well, we're building the plane as we were flying it. And honestly, I still feel that way sometimes, but I think that the plane has been built and it is on a great trajectory. Excuse me. We've come a long ways since those meetings in Walla Walla. We're 1 ACH, but we have 7 local health improvement networks, 82 provider sites that we're working with, earning over $43 million in incentive payments to date. We have invested $3 million to support our communities to address social needs. We've had regional health campaigns with great impact, such as Practice the Pause and our ACEs campaign. We've distributed millions of items of PPE. We've helped stand up a COVID test site locally. We've held a masking campaign. We did a COVID support for skilled nursing and assisted living personnel and residents. We held a virtual press conference before it was the norm. We've hosted an opioid summit, a chronic disease summit. We've helped start a permanent supportive housing facility. We've instituted a behavioral health preceptor program, a community health worker program. We have a diversity, equity, and inclusion program. And we have even witnessed the first of what we hope to come, a value-based payment contract for behavioral health. Way to go, Merit Resources and Martine. It's really been a team effort. We have strived to be the Nordstroms of ACHs, offering excellent customer service and value. And I truly believe that GCACH will accomplish even more in the days and years ahead, especially with Sharon at the helm. She is a connector and a respected leader. GCACH is so lucky to have you, Sharon, as our advocate and our friend. I cannot say enough thank yous to my GCACH staff and the board and everyone who has helped build up this organization, lifted us off the runway and kept us airborne. I will miss our time together, creating new programs, overcoming doubt, hearing those provider success stories, and again, our wonderful board members and the baby spam that we get to see every Monday. I might even miss writing those semi-annual reports. No, actually I won't miss writing them. So those are my reflections, Patrick. Not exactly a Timothy Egan, but it's been a really busy week. and a really busy 7 years.
Right.
I do have some advice, however, that I'd like to pass on to Sharon. Sharon, this job gets really complicated, and as an executive director, you will have all sorts of problems to solve and lots of decisions to make. Running a small nonprofit business can be pretty frustrating, exasperating, and exhausting. So sometimes you just have to make the decision, press the easy button. Fortunately, I have an easy button given to me by my secret Santa, Diane, who knows a lot about my sense of humor. And I am bequeathing this precious easy button to you to use when the decisions seem impossible and you need a little guidance. Use it wisely, Sharon, and it will never let you down. Thanks, everyone.
Thank you, Carol. Well, the accolades are pouring in on chat, and Stacy, I hope that the chat will be memorialized here in archive so Carol can just savor those at a certain point. But before we leave each other for the year, is there anybody who would like to pipe up and say something embarrassing to Carol? Everyone's pretty shy.
I would pipe in here. Ben Shearer, Pasco Fire Department. I was not back there in the original beginning of the ACH meetings, but shortly after they started getting organized.
Wait a minute, is this Eric? Are we
No, Ben Shearer, Pasco Fire.
Okay.
And I remember I'm not a meeting person. I'm much more of a doer person. And Pasco Fire had a lot of plans, and we wanted to do a lot of things, and had several sit downs with Carol and helped us understand the need for all this pre-planning and all these meetings that were happening to try and really figure out what was happening in our community so we could all come together and work together. And it's been an amazing experience, and I want to thank her for her patience with me and the time that we put in here. And it's great to see, we were just discussing in our office the other day the amazing things that's happening here at GCACH. And because of all the pre-work that went in from all of you all here on this meeting now, and the pre-work, and we got, you know, the background, the appropriate background work done so that we can move forward successfully. And Carol, I think, was, at least on our end of it, the one that kept us at a good pace in order to not get ahead of the cart. And I appreciate that effort and appreciate the time, Carol. Looking forward to continuing the effort here in Tri-Cities, and as well as the rest of the GCAH, and making great partnerships and great movement, and seeing what else happens towards the future.
Thank you.
Thank you, Ben. Any other quick comments? Some wonderful thoughts in the chat. Well, Carol, we are going to miss you.
I just wanted to say thank you from Barth Clinic. This is Lindsay. You know the position that we were in when we first came to GCACH with the BHO. And I just wanted to say thank you. Great. So you believed in us, and you know, we've done our best to make you proud. And I just want you to know that we are very grateful for everything that you did for GCACH and what you've done for us. So thank you.
You've made us proud, Lindsay.
Thanks.
Thank you, Lindsay. All right. I think it's safe to say that we all feel we're in a better place than we were when the ACH started 7 years ago. And so much of that is due to Carol's Energizer Bunny work ethic and her cheerfulness and her organizational skills. So Carol, just speaking from somebody who was there in the Walla Walla second floor room in 2014, this has been quite a journey. But before we break, any other final comments? All right. Well, Carol will be around, so she's not leaving after this meeting. So if you would like to contact her, I think Sharon has, as I mentioned at the start, had her tethered to the office for a few more weeks, and I'm sure she'd like to hear from you. There will be, as we've done in the past, there will be no meeting in December. but we will certainly reconvene in January. Topic to be determined, but just rest assured we're working on that. And then again, if you wouldn't mind taking the survey, we'd greatly appreciate that. We use this feedback to both look at the format of our programs as well as the content. So please take the 2 or 3 minutes that would be helpful to give us that kind of feedback. So with that, a lot of emotion today. Let's end on a joyful note and wish everyone a wonderful Thanksgiving and a holiday period. And we will see you all in mid-January. So take care and God bless.
Thanks. Thank you, Patrick.
You bet.